Hello, everybody. Thank you for joining this SCCT video. My name is Anna Flayhaven. I am the CT product marketer for our US and Canada region here at GE Healthcare, and I'm very excited today to introduce Dr. Grantham, who is located in Northern Indiana and works at the Beacon Health System, to walk through coronary CTA and what they've learned by handling some tough cases. Dr. Grantham, I'll turn it over to you.
Oh, thank you. Yeah, so anyway, a little bit more about myself. We cover 9 hospitals up here and several imaging centers and doctors' offices. I'm a private practice radiologist, so probably a different point of view than you usually hear in these talks. Uh, Coronary artery disease, briefly, it's the most common cause of death in the U.S. It accounts for about a quarter of the deaths each year in the United States, and each year greater than 600,000 people die from heart disease in the U.S. So certainly some room for improvement to get these numbers down here. So how do these patients usually present? Most often with chest pain, but they can also present with other symptoms. How do you work up your patient with chest pain? Well, the first thing you need to determine is the chest pain a cardiac source? And if it is coming from the heart, is there ischemia? Because ischemia left untreated can have negative effects on the patient's morbidity and mortality. Ischemia is a lot like economics. It's really a problem of supply and demand, and there's a number of factors that go in to determine whether the supply is meeting that demand and causing ischemia. And there's a number of different tests that you can order for your patients to figure out if they do have ischemia, and we'll briefly touch upon those. Invasive coronary angiography has traditionally been the gold standard to evaluate patients for ischemia. A lot of benefits. It's got a very high temporal resolution, high spatial resolution, and has the benefit that you can potentially fix the problem while you're in there. Disadvantages, it's expensive, it's invasive, so there's a potential for complications. It uses iodinated contrast and radiation. And it's really only telling you about the supply side of the ischemia equation. It's not really telling you what's happening with the tissue downstream. It's pretty easy, though, when you have a high-grade stenosis like this to say there's probably ischemia and that needs to be treated. But what do you do for the intermediate lesions, the 50 to 70% lesions? Does something need to be done for these lesions? There's really no way to know based on these images alone. Not all of us have the same size coronary arteries, which is a factor. Most of the time with invasive coronary angiography and conventional CT, we're using percent stenosis to decide whether a patient needs treatment. And it's really a more complex problem than just percent stenosis to determine if they have ischemia. Patient on the right, they have a smaller LAD, 32% stenosis. The vessel diameter is 1.2 millimeters. Patient on the left, larger LAD, their percent stenosis is 57%, but their vessel is actually larger there. So even though they have a higher percent stenosis, the vessel is larger where the stenosis is occurring. So which patient is actually having ischemia? It's pretty hard to tell just based on percent stenosis and these images alone. Also, on the demand side of the equation, some vessels have more demand on them. The patient on the left has a very long LAD. It wraps around the cardiac apex. It's distally bifurcated, so it's probably supplying a large amount of myocardium. Where the patient on the right has a short LAD, it's terminating before it gets to the cardiac apex. So it's supplying less myocardium and more likely to tolerate a higher degree of stenosis before that patient has ischemia. So how do you tell in the cath lab whether a patient has ischemia or not? Well, a good way to tell is by doing invasive FFR. And when they do invasive FFR, what they do is they put a wire into the vessel that has the stenosis. They measure the pressure distal to the stenosis and proximal to the stenosis simultaneously while they give a drug to dilate it up, frequently adenosine. And that ratio of the pressure distal to the stenosis and proximal to the stenosis gives you your fractional flow reserve, which is a very good estimate to what's going on in the vessel. It takes into account both the supply side as well as the demand side of that equation to determine if there's ischemia. It does have its problems. It's a fairly stiff wire and the heart is moving. So there's a potential while that wire is in there that it could damage the vessel and cause problems. And also, it's a fairly stiff wire. Going around corners are sometimes difficult, so not every vessel can be evaluated with FFR. This is what it looks like in the cath lab when the vessel is at rest, no vasodilator. The pressures are equal or nearly equal, proximal and distal to the stenosis. You give the vasodilator. The pressure drops off disproportionately distal to the stenosis, and that gives you your fractional flow reserve. Nuclear medicine stress has traditionally been one of the mainstays for evaluating patients non-invasively for ischemia. And it's a lot like invasive FFR. It's a stress test. It requires the vessel to be dilated either through exercise or medications. And the reason they dilate up the vessel is if you only looked at it while it was at rest, you would need at least an 80% stenosis before you saw a drop off in flow. And that curve is relatively shallow. There's really probably not going to be much difference in the uptake of the radiotracer with nuclear medicine at 80% or 90%. So you may not even see a difference until you're getting into your critical stenoses with nuclear medicine if you only looked at rest. So you dilate up the vessel, you try to get them maximally dilated because then you start to see a drop off in flow at 50% stenosis, and the slope of that curve is much steeper. If nuclear medicine was perfect and very sensitive, you'd pick up 50% stenoses, but you really have to be further down that curve before you see a difference in uptake. It's usually felt you need a 70% stenosis before you see a lesion with nuclear medicine, and maybe even miss a few of those as well. So if there, well, with that being said, there is no perfect test, but if there was a perfect test, what would it look like? It would have high sensitivity, high specificity, a high negative predictive value. It would tell you whether there's ischemia or not just the supply side of the equation. And it would have very little radiation dose or no radiation dose and be non-invasive. And coronary CTA, at least with FFR, checks all those boxes. And it has the benefits of being able to find non-cardiac sources of chest pain that would be messed with other imaging techniques, and improved outcomes compared to traditional testing. As far as radiation dose goes, it was a busy slide, but nuclear medicine SPECT is around 11 millisieverts. CT, prospectively, is in the 1 to 3 millisievert range, and that's where most of our patients are, because most of our patients get prospective gated studies. If you did retrospective gating, full cardiac cycle, you could potentially be up to 12 millisieverts, but that's extremely rare that we use that. Diagnostic cath is about 7 millisieverts, and diagnostic cath with intervention, 17 millisieverts. So as far as sensitivity and specificities go, this is an older study. I suspect with newer studies, you'd probably be doing a little bit better. But in general, coronary CTA is a highly sensitive test. It only has a low to intermediate specificity. Nuclear medicine SPECT has less sensitive, only intermediate sensitivity, but higher specificity. And the white dot here, that's stress echo, fairly low sensitivity, but improved specificity. And coronary CTA with FFR really does very well compared to the gold standard. And in this study, the gold standard was invasive FFR. So really the closest to invasive FFR of any of these tests here. And coronary CTA also comes with the benefit of what has been called a warranty, which is really somewhat of a misnomer. It just means event-free survival. Some studies have found that if you have a completely normal coronary CTA, you can have up to a 10-year event-free survival rate against cardiac death and non-fatal myocardial infarction. And why is that? Well, again, it's just because this high level of sensitivity comes with a high level of high negative predictive value. Some studies have found up to 99% of negative predictive value, and none of those other tests can claim that. This is the Scott-Hart trial. What they did with the Scott-Hart trial is they took patients that came in with chest pain, and they divided them into two groups. One group whose care was directed by stress testing, which is considered standard care, and the other group, their care was directed by coronary CTA. And the treatment decisions were based on those evaluations. And then they followed them for 5 years after their initial presentation, just to see how they did. And what they found is at 5 years, the CTA group had nearly half the myocardial infarction rate, as well as nearly half the death rate from myocardial infarction. And again, why is that? It's because of this high sensitivity. You're picking up patients who have disease, getting them appropriate treatment where standard care might be missing those. So how do you get these good results for your patients? Well, you need good images, which brings up the saying, anything worth doing is worth doing well. A very good predictor of your image quality is your rejection rate if you send your studies off for FFR. If you have a high rejection rate, your image quality is often subpar. And the way they evaluated in this study, determinants of rejection rate, they looked at old studies that were done on, older scanners and newer studies that were predominantly done on newer scanners. And what they found was the newer studies that were done on these newer scanners had a lower rejection rate. There were other factors as well that were very important. The newer studies had better heart rate control, so that is certainly a factor. And they had also just better protocols, thinner slices, higher temporal resolution, which also comes with the newer scanners, and better bolus as well. So we've come a long ways. We started back in 2007 doing coronary CTAs on a 64 slice scanner. It had 0.35 rotation speed, and our studies were pretty challenging back then. Now we have newer scanners, so life is a lot easier. We get better image quality, and it's just really much easier to scan these patients currently. So in 2018, we got our first wide detector CT, and we also have a dual source scanner we got in 2019. So we have 2 of these wide detector CTs, 2 dual source scanners, and we also have some 128s that we do an occasional CT coronary on as well. And they both have their strengths and weaknesses. Narrow detector CTs, whether you have a dual source or a single source, it's a pretty complex decision tree. Are you going to flash the patient if you have a dual source? And with a single source or dual source, you have to decide whether you're going to do a prospective or retrospective, and how much of the cardiac cycle you're going to cover. And this is what it looks like. to do a prospective or a retrospective study, either with a single source or dual source. It looks exactly like this, no matter which type of scanner you have. And so the one on the left is prospective CT. We're acquiring at 70% of the R to R, which is sort of mid-diastole. The tube is on right here. That's what that solid line means. That's where the tube is on. And prospective imaging is step and shoot. So it's taking an image and then it's moving, taking an image and moving, and so on. This is a 4 centimeter scanner, so it's taking 4 acquisitions to get all the way through the heart and 3 heartbeats to move as well. So 7 beats to get all the way through the heart prospectively with a 4 cm scanner. This is on the right is a retrospective study, 6 beats, and retrospective is a spiral CT, so the table's moving at a constant velocity. The tube is on during the whole study, so it's a higher radiation dose. It's not on 100% of full energy the whole time, but it is on throughout the study. So it's a higher radiation dose is kind of the drawback to it, but because you're acquiring 6 beats, you have some overlap of data, which improves your odds if the patient has an arrhythmia. You could potentially do what's called ECG editing. You could go in and take out one of these beats, which works if you just have a single beat that's bad. But if you had 2 beats right next to each other that were bad, you can't really ECG edit out that bad beat because there's no good data overlapping. And also, the way we do most of our retrospective studies is we do a systolic to diastolic, a 30 to 70% retrospective. And unless you're acquiring the entire cardiac cycle, often you don't have enough data to do ECG editing. So what we end up doing is actually just kind of piecing the coronary arteries together based on what we have here, rather than doing ECG editing, because we try not to do the whole beat retrospective because that's a pretty high dose. So what happens if you go down the wrong branch of that decision tree is an example here. We had a newer tech, and she did this patient prospective during diastole. Systole tends to be more predictable when you have an irregular heart rate. This patient has atrial fibrillation, so they're irregular. Systole would have been a better decision, and even retrospective would have been even better. And what happened was during this step and shoot study, while the table's moving, was right at the horizontal portion of the left anterior descending. And we got this skip in the left anterior descending, and so you're left with a decision. There's no way to save this. There's no overlap of data in this prospective study. You can't ECG edit. So you're left with the decision: are you going to bring the patient back, do them retrospective, or just read it out the way it is as a limited study? Which may mean they might need additional testing with nuclear medicine or stress echo. We chose to bring him back on a different scanner. And there's a couple reasons why. One, we brought him back on a Y detector scanner because that is a single beat acquisition all the time. And I feel it is, you have a better odds of triggering with a 1 beat acquisition during a good beat with a single beat acquisition. And why is that? Well, let's say 1 out of 6 beats were bad. With a single beat acquisition, you have 1/6 chance of acquiring on a bad beat. So the chances of you acquiring on a good beat are actually very good. Whereas if you have a 6 beat acquisition, the chances of you acquiring images on a bad beat is very high. So I feel at least that the Y detector scanners do a better job for the irregular heart rates. Now, you could do retrospective on the patient and piece things together and still get a diagnostic study most of the time. But I feel your odds are better with the wide detector CT. Also, this patient already had a CT, so bringing them back for retrospective, which is a higher dose. Having two CTs, one prospective, one retrospective, would have been a higher dose than coming back and having another prospective study. The wide detector is always done prospective, so the dose is always fairly low. So we got a diagnostic exam on this patient with one beat. We got the entire left anterior descending, and if you take a look at the images, they're a little bit grainy. This was an older study on our wide detector CT. Now we have a better tube on that scanner, so we get better looking images as well as deep learning reconstructions. So this is what it would look like if we did that patient now. We would have much better looking coronary arteries. There's no graininess here. We have deep learning and reconstructions that get rid of a lot of that graininess and improve our image quality. So even though this is a pretty wide acquisition, here we're getting quite a bit of the cardiac cycle. Our dose is still 1.6 millisieverts, so still a low dose because it's prospective every time that you do one of these studies on this scanner. So another patient with an irregular heart rate. And the way to improve your odds with these difficult patients that have irregular heart rates is to acquire more of the cardiac cycle. That, of course, does come with a larger radiation dose, but since this is prospective, it's really not much of a change. So the last patient was narrower, their dose was lower. This patient's a little bit wider acquisition, so it's 1.7 millisieverts, still much lower than if you did a retrospective study. Next patient, this patient is really probably the most difficult type of patient to do. They're both fast and irregular. So to improve your odds of getting a good study, you do an even wider acquisition, which is what was done in this case. One way you can do 0 to 100 is a complete heartbeat. This patient was actually done more than that. It looks like it was probably done as a 0 to 150. We've done that on a few patients with kind of variable success rates. But it's more data, gives you a better chance of getting images that are diagnostic, the more the cardiac cycle you acquire. So in this case, you'd be acquiring 2 systoles and 1 diastole. And since systole tends to be a little more predictable in these highly irregular patients, that's the goal. It actually ended up being almost 2 full heartbeats, though, because it acquired at 2 rapid heart rates there. And still, even though it's almost 2 full beats that we acquired, the dose is very low, 3.4 millisieverts. That's pretty low. So yeah, back to this decision tree. One of the main benefits, at least as far as training techs, to the wide detector CT is the decision tree is really much simpler. You don't have to pick prospective, retrospective, or flash. It's just prospective all the time. The only decision is how much of the cardiac cycle you're going to acquire and whether you're going to use smart arrhythmia or not. So anyway, we've had significant improvement since we upgraded our wide detector. We just did that last year. We still have 160 millimeters of coverage, but now we have the better tube. Before our tube did have some challenges with bigger patients. It's a pretty smart scanner. You do your scout and it would tell you if you were going to be able to reach your noise index or not. If you couldn't reach your noise index, it would give you some recommendations, which was often increasing your kV. So our larger patients were often done at 140 kV. which it automatically lowers your MA. So they're often done at a 700 MA. Now with our better tube, we can do most patients at 120 kV, and we have plenty of MA for those patients, which improves our image quality without really changing our dose at all. Might even be a lower dose now. We have the deep learning reconstruction that gets rid of that graininess and makes our images really sharp. Our temporal resolution went up. We went from 0.28 rotation speed down to 0.23, and we got a newer version of their software. It's called Snapshot Freeze 2, which helps freeze the motion of the heart. The workflow was always, fairly seamless because you didn't have that decision tree, but the amount of decisions that the techs need to make now are even less because, we're not at, pushing the tube's abilities now. Most patients are done at 120, and so they're not having to change the technique to get these larger BMI patients done. Smart arrhythmia can be helpful in selected patients. I find it works better for patients who have low to intermediate variability. Maybe the high variability patients, you could use other techniques actually to improve those images. But so what is smart arrhythmia? It's basically senses when the acquisition is on a bad beat, and it'll acquire the next beat. So with this patient here, like if the acquisition happened on the 151 beat right here, it would sense that that was a bad beat, and it would acquire the next beat, which in this case would have been a 53. So you would have a diagnostic study, a high probability of having a diagnostic study if you used smart arrhythmia and it just happened to trigger on that 151. But if it triggered out here on the 133, your next beat would have been 137, and probably wouldn't have helped as much. Still yet, it would have helped probably because the more data you have, the more likely you are to have a diagnostic study, but it wouldn't have been as big a help as if it would have happened here. So it works great for your lower to intermediate variability patients. High variability patients that are high and fast, it's only marginally helpful in those patients. So yeah, we've really noticed improvement when we went to 40 to 160, and now upgrading our 160 has really improved things as well, especially now that we have the better tube and the higher temporal resolution. I feel we have fewer rejections when we send our studies off for fractional flow reserve. Also, we're a little more flexible with our heart rate. Before, if a patient came down from the floor or an outpatient came in that had a higher heart rate, we were often sending them back to the floor or home with more medications and to try and get their heart rate down. Now we're often just doing them with the higher heart rate and usually getting a good study. So that's helped as well. So who should have this test? In 2021, multi-societal guidelines came out, and there are multiple indications for coronary CTA with varying evidence and levels of recommendations. But the highest recommendation, highest level of evidence was for patients that are in the intermediate to high risk category that have stable chest pain, 65 or less, as well as the intermediate risk patients that are coming in with acute chest pain. You can do them right out of the ER with the highest level of evidence and recommendation in those patients. And why 65 or less? It's because the high calcium scores that older patients tend to have. You can still use it in those older patients, and we frequently do. It's just your accuracy is going to go down. Hopefully that'll improve with newer scanners, newer detectors. Also, another one I'd like to point out is it can be used as an adjunct to conventional stress testing. Before, if you had Positive nuclear medicine test, you were often taken to the cath lab, and there was a potential that that nuclear medicine test would have been a false positive, and the patient didn't need to go for that invasive test. Now you can use coronary CTA to sort those out to see if it's a false positive, as well as you can use it for those patients who had a negative stress test and are still having chest pain, just to see if that was a false negative. Coronary CTA can also sort those patients out, and as well be used in larger stents and in patients with CABG and other indications as well. So another challenging type of patient is your large BMI patients. And there are some tricks you can do to keep your image quality up. Our BMI cutoff with our old tube was 40. We only raised it 5 with our new tube. Our BMI cutoff is 45 now. But our image quality certainly did improve on those patients with the new tube. And some of the tricks that you can use for these large BMI patients, is you can slow your tube speed down, which will give you a little more dose. But you got to be careful. You can only really do that in patients who have low heart rates. This was a young patient, so they're likely to have a low calcium score, and she had a low heart rate. Her heart rate was 50. So we did her, and this is even on our old tube. So we used 0.35 rotation speed. We used 140 kV, and we still got a diagnostic study, even though she was well over our BMI cutoff back then of 40. And I feel now with our newer upgrades, we have even more room to play around and push our BMI limit, because now we're at 0.23, and you can always raise it to 0.28, or even if you had a very large patient, up to 0.35. And so we have a lot more room to play with right now with our better tube and our faster rotation speed. And so this patient ended up having apical variant hypertrophic cardiomyopathy, which was actually missed on her echo. And not surprising at that BMI. So yeah, one of the benefits of coronary CTA over traditional testing is your ability to find non-cardiac sources of chest pain, and often these non-cardiac sources are still important to find. We've found several patients that have PEs that were unexpected. This patient had a PE and a pleural effusion and a pulmonary infarct. This patient had a lung cancer, and if a lung cancer is abutting the pleura, it could potentially be causing chest pain. We picked up a number of those as well. Anomalous vessels, of course, anomalous coronary arteries, some of them with malignant courses, we picked up. This patient had partial anomalous pulmonary venous return. We picked up a few of those. If you had done traditional testing, you would have likely have missed. So hopefully by this time I have you convinced that coronary CTA should be the first line in evaluating your patients, and because it really does check all the boxes and has the benefits of finding non-cardiac sources of chest pain. And at least compared to traditional testing, you can improve outcomes for your patient. So where we are now, I kind of went over that already, where we would like to go, because of the simplicity of our wider detector scanners. We have more techs trained because it's really a lot easier. The decision tree is a lot simpler. Back when we were on a 4-centimeter single source scanner, we only had 1 or 2 techs that were able to do our coronary CTAs. Now we have 6 or 7 techs in that same hospital that are doing coronary CTAs. So we're planning to extend our hours, do nights and weekends, hopefully, and our heart rate control, we can be a little more lax with that, although I think we still are going to do our best to get those patients as close to 60 whenever we can. Hopefully in the future, there will be AI that's smart enough to predict when the scanner should trigger. I mean, they can predict stock markets. Why can't they predict when it should trigger in a patient with arrhythmia? So I don't know if that's even possible or if anybody's working on it, but that is something I would like to see in the future. Hopefully through, with improved detector resolution, we'll be able to do patients with higher calcium scores more accurately, as well as do stents. Another thing I'm looking forward to is there's something called that coming out. It's called ECG-less gating. We cover two of the busiest ERs in Indiana, and we really don't have time to gate our dissection protocols. And most of the time we're fine. We use a high-pitched spiral, and usually there's not much motion, but I'm always looking for ways to improve our image quality. So hopefully ECG-less gating will do that for us. Any questions?
Thank you so much, Dr. Grantham, for going over those slides. And if there is any questions for any of this content that was reviewed today, please feel free to reach out to SCCT, and they would be glad to get you connected with either a GE healthcare rep or Dr. Grantham. Thank you.